Hi guys, so these are the Chapter 9 key points. Chapter 9 has quite a bit of information in it because it is covering Medicare, and Medicare is a substantial part of our health insurance system. We have a great deal of people on Medicare, so we're going to go kind of quickly through this chapter and these key points. This information is all in your textbook, so I would strongly encourage you to read the Chapter 9 in its entirety, so that way you can have a little bit better understanding. All right, so we are going to start with the differences between Medicare Parts A, B, C, and D. So Medicare Part A helps pay for inpatient hospital services, also helps pay for care in a skilled nursing facility, home health care, and hospice care. The fees that are paid by Medicare Part A for inpatient hospital services are going to be based on a grouping of diagnoses, so that's important to remember. People who are eligible for Social Security benefits are automatically going to be enrolled in Medicare Part A, and they don't have to pay insurance premiums. Although people age 65 or older who do not qualify for Social Security benefits have the option of enrolling in Part A, technically they must pay in order to get pay premiums in order to get those benefits. So Medicare Part B helps pay for physician services, for outpatient hospital services, for durable medical equipment, medical services, clinical laboratory services, home health care, and blood supply. Many preventative services are also covered under Part B, and every year more preventative services are included as these provisions from the Affordable Care Act are implemented gradually. So they are set to become effective in specific years as they are laid out. So eventually more and more preventative services will be added to Medicare Part B coverage. Part B coverage is optional. Everyone who is eligible for Part A may also choose to enroll in Part B, but they have to pay monthly premiums, and those are usually deducted automatically from Social Security retirement benefit payments. They are also subject to an annual deductible and co-insurance, which are amounts that are established by federal law. So Part C is originally called Medicare Plus Choice, and it's available to individuals who are eligible for Part A and who are enrolled in Part B. So under Part C, private health insurance companies can contract with the CMS to offer Medicare benefits through their own policies. Lastly, we have Medicare Part D, and those Medicare Part D, is authorized under the MMA, and that provides voluntary Medicare prescription drug plans that are open to people who are eligible for Medicare. All Medicare prescription drug plans are private insurance plans, and most participants have to pay monthly premiums to access discounted drug prices. So next, we're going to compare the original Medicare plan and Medicare Advantage plans. So Medicare beneficiaries who enroll in the Medicare fee-for-service plan, and that's referred to by Medicare as the original Medicare plan, can choose any licensed physician certified by Medicare. They must pay the premium, the co-insurance, which is 20%, and the annual deductible specified each year by the Medicare law, and that's voted on by Congress, the amount of deductible, the annual deductible. Okay, so then there are a couple of other types of plans that I want you to know about as well. And these are they can enroll in these instead of the original Medicare plan. There's a CCP, and that is a Medicare Advantage Coordinated Care Plan. That's a coordinated care plan that includes providers who are under contract to deliver the benefit package approved by CMS. So many CCPs are run by the same major payers that offer private or commercial coverages, and CCPs may use features to control utilization, such as requiring referrals for primary care providers to go see specialists. They may encourage cost-effective care, that sort of thing. The next one is fee-for-service, and that is under a Medicare private fee-for-service plan, patients receive services from Medicare-approved providers or facilities of their choosing. The plan is operated by a private insurance company that contracts with Medicare but pays on a fee-for-service basis. The last one is MSA, and that's Medical Savings Account, and it's similar to a private medical savings account. It combines a high deductible fee-for-service plan with a tax-exempt trust to pay for qualified medical expenses. The maximum annual MSA plan deductible is set by law, And the CMS pays premiums for the insurance policies and makes a contribution to the MSA. The beneficiary then puts in the rest of the fund. Beneficiaries are allowed to use the money in their MSAs to pay for their health care before the high deductible is reached. At that point, the Medicare Advantage plan offering the MSA pays for all expenses and covered services. Okay. On to the next point of calculating fees for participating physicians and for non-participating physicians when they do and do not accept assignment. Okay, so annually, physicians are allowed to choose whether they want to participate in the Medicare program, and participating physicians have to agree to accept assignment for all Medicare claims and to accept Medicare's allowed charge schedule. Excuse me, as payment for in full services. So that's if they accept Medicare assignment, then that's what they're getting paid. What Medicare says they're getting paid is basically what I'm talking about here. So a physician may bill the patient for coinsurance and deductibles, but may not collect amounts higher than the Medicare amount allowed by the fee schedule. Medicare is responsible for paying 80% of the allowed charge, and that's after patients have met their annual deductibles. So patients are responsible for the other 20%, and then the physician may bill the patient for services that are not covered by Medicare, so that's what they're allowed to do. Non-participating physicians are going to decide whether to accept assignment on a claim-by-claim basis. Providers who elect not to participate in the Medicare program but who accept assignment on a claim are paid 5% less for their services than are those contracted physicians. For example, if the Medicare allowed amount for a service is $100, the contracted provider is going to receive $80 because that's 80% of 100. And the non-contracted provider is going to receive $76 because that's $80 minus 5%. The non-contracted providers who do not accept assignment are subject to Medicare's charge limits, which means they may not charge a Medicare patient more than 115% of the amount listed in the Medicare non-participating fee schedule. So that amount, the 115% of the fee listed in the non-provider fee schedule, is called a limiting charge. So be aware of that. Okay, so to complete an advanced beneficiary notice of non-coverage, those are ABNs. You'll see ABNs quite often when you work in a facility that accepts Medicare patients. So the ABN has 5 sections and 10 blanks. So blanks A through C are the header. This section has to be completed by the provider before the form is given to the patient. Then you have section 2, which is so blank A is the notifier, which is where you're going to enter the provider's name, address, telephone number. If the billing and notifying entities are not the same, the name of more than one entity may be given in the notifier area as long as the additional information, which is the H section, is below on the form states who should be contacted for questions. So blank B is the patient name. Blank C is the identification number. This is an optional field. You can choose to enter an ID number for the beneficiary, such as like a medical record number that helps link a notice with a related claim. But you cannot use Medicare numbers or Social Security numbers on the ABN notice. Blank D are the descriptors. And so that's item, service, lab test, tests, procedures, care, equipment used, anything like that. So the notifier must list specific items or services believed to be non-covered under the header of blank D, so under Part D. For general descriptions of specifically grouped supplies are permitted. For example, wound care supplies would be a sufficient description of a group of items used to provide wound care. An itemized list of each supply is generally not required for these ABNs. When a reduction in service occurs, this needs to be made clear to the beneficiary. For example, entering wound care supplies decreased from weekly to monthly would be appropriate to describe a decrease in frequency for this category of supplies. But just writing wound care supplies decreased is insufficient. So for blank E, it's the reason Medicare may not pay. In this blank, the provider or notifier must explain in beneficiary-friendly language, so the patient has to be able to understand it, why they believe the items or services described in blank D may not be covered by Medicare. Commonly used reasons for non-coverage are Medicare does not pay for this test for your condition. Medicare does not pay for this test as often as it's ordered, so it's denied. It will be denied as too frequent. And Medicare does not pay for experimental or research use tests. So, for example, if a patient is ordered to have cholesterol tests drawn every month, but that Medicare is only going to pay for it once every 3 months, then you would have an ABN for them for those additional 2 months because Medicare is unlikely to pay for it. Okay, so in order for it to be a valid ABN, there must be at least one reason applicable to each item or service listed in the blank D, and it can be the same for all the items that you've listed there. So blank F is the estimated cost, blank G, there's different options there. All of this stuff is in your textbook. You want to definitely read through this. Blank H is additional information, and then lastly, we have the signature box, and that's important. Once the beneficiary reviews and understands the information contained in the ABN, the signature box can be completed by the beneficiary or his or her representative. The box cannot be completed in advance of the rest of the notice. So the whole form has to be filled out, then they have to sign. They have to sign, and the beneficiary must sign and date the notice to indicate that he or she has received the notice and understand its contents. If a representative signs on behalf of the beneficiary, he or she should write out representative in parentheses after his or her signature. The representative's name should be clearly legible or noted in print, and the disclosure statement in the footer of the notice is required to be included on the document, so it can't be cut off if you're copying it. Okay, so determining whether Medicare is the primary or secondary payer in a given situation. Benefits for the patient who has both Medicare and other coverage are coordinated under the rules of the Medicare Secondary Payer Program, which is the MSP program. The Medicare Coordination of Benefits contractor receives inquiries regarding Medicare as a second payer and has information on the beneficiary's eligibility for benefits and availability of other health insurance that is primary to Medicare. Here's what you need to know. Medicare is going to be secondary if they have any other insurance. If they have Medicaid and Medicare will be primary. So other than that, there's some information here for you that you can check out and read through that as well. And then again, definitely read through the lecture notes and then in your textbook. All right, so lastly, preparing an accurate primary and secondary Medicare claims. CMS mandates electronic transmission of Medicare claims. They do not take paper claims any longer. And Medicare law requires claims to be filed within 1 calendar year after the date of service. So a couple of things to note here. Medicare law sets specific guidelines for timely filing of claims for benefits. The Health Reform Law, which is the Patient Protection and Affordable Care Act, required a change in Medicare timely filing of claims for Part B providers. Previously, Medicare law required the claim to be filed no later than the end of the calendar year following the year in which the service was furnished. So if you went to the doctor in January of 2014, you basically had until December of 2015 to file a claim. Well, they figured out that that wasn't working out so well, so they came up with these new laws. The new law requires claims to be filed within 1 calendar year after the date of service. When filing a late claim, be sure to include an explanation of the reason for the late filing, and then you have to have evidence to support that. Late claims may be paid if the lateness is due to a good cause, such as Medicare administrative error or an unavoidable delay, or if there was accidental record damage. Okay, so that's it for Chapter 9. That's a whole lot of information in about 14 and a half minutes. So you definitely want to read through this chapter. Medicare is kind of a big deal. And then be sure that you work on those claim forms and Connect for Chapter 9 as well. Talk to you soon.